for doing that. We see it. We are recording as well so that we can also share our learnings with our larger membership. But we're so glad to have everyone here. We'll give it about 10 more seconds so folks can continue introducing themselves in the chat before we get started. Alrighty. I am Felicia Singh, Director of Policy and Government Relations at CACF. My pronouns are she, her, hers. We are so grateful to have you at today's webinar on the health and wellness of New York City's LGBTQ AAPI community, along with a needs assessment and data disaggregation briefing. You'll be hearing from team members of CACF, as well as team members of Apicha, who will be sharing so much about their learnings and their report in understanding our communities and our LGBTQ's needs. If this is your first time joining us, joining CACF's webinar, CACF is the Coalition for Asian American Children and Families, and we are the nation's only Pan-Asian Children and Families Advocacy Organization. We bring together community-based organizations, as well as youth and community allies to fight for equity for our API community across the state. We are so grateful to have you share your time with us and continue to learn with us as well. If you have questions throughout this presentation, you could feel free to put it in our chat. But for now, I'm going to pass this on to our Senior Policy Coordinator for Health, Medha Ghosh.
Thank you so much, Felicia, and thanks for starting us off. Thanks all for being here. As Felicia mentioned, my name is Medha. I'm the Senior Policy Coordinator for Health here at CACF. I'm delighted to introduce our presenters from Apicha Community Health Center today, who will be providing a look into the findings of their amazing needs assessment on the LGBTQ plus AAPI community in New York City. Before I do, I wanted to ground today's briefing in CACF's health equity work, which has allowed us to collaborate with partners like Apicha. So the way we really understand health equity is envisioning an equitable healthcare system in which all marginalized communities, which includes our AAPI community, are able to center their well-being free of oppression in all of its form. An equitable healthcare system for the AAPI community must be rooted in culture responsive and linguistically accessible care. Next slide, please. And so the way we do this and we achieve our try to achieve health equity in our work is through 5 fundamental processes. One is community-based research for data-driven action, which is something that we're really focusing on today. Coalition building for community-centered solutions, which is how we do our work and able to connect with partners like Apicha. Implementing inclusive and equitable policies, and increasing representation of marginalized communities in healthcare leadership and governance roles, as well as investing in shared and systemic accountability. Would love to connect with all folks who are interested in this work. You can always email me, as you can see below. And now we'll get started with introducing our presenters from Apicha. So our first presenter is Melanie Dulfo, the Director of Community Health Education at Apicha Community Health Center. She's a licensed master's in social work with concentration in community organizing and advocacy. Our second presenter is Glenn D. Magwepante, served as a principal investigator for Apicha's LGBTQ AAPI Health and Wellness Needs Assessment. He's a long-time civil rights attorney, professor of law and Asian American Studies, and LGBTQ rights activist. Thanks all. Well,
Thank you so much, Medha, and thank you to the team at CACF. I'm so happy and honored to be here with you all. We've been working with CACF for a long time, and I actually remember that the first time I had gone on advocacy, actually going to Albany and like working with a group of a contingent of CACF staff and members was with CACF actually. It was when I was like I think it was like my first or second year in my job at Apicha. So I have very fond memories of CACF and having my first like advocacy experience with y'all. So that was actually a very eye-opening experience for me. I thought that y'all back then was really organized, and so happy that we're still part of the coalition. So welcome everyone. My name is Melanie Dulfo. I'm the Director of Community Health Education at Apicha Community Health Center. And we're here to share about the survey findings of our health and wellness needs of LGBTQ Asians and Pacific Islanders. A study that we undertook with Gwen Magpantay as our primary investigator. And so I also wanted to just say, you know, I really am excited to see a lot of our CBO partners as well as our government partners in the meeting today. So really excited to be sharing this with everyone. Okay, so I'm gonna just ask to move on to our next slide. Apicha Community Health Center started out as an AIDS service organization back when Asians and Pacific Islanders living with HIV was doubly invisible, both to the people that was working in HIV, right, and also in our mainstream API institutions. And so established as Asian Pacific Islander Coalition on HIV/AIDS, Apicha soon developed, you know, taking on case management that was bilingual case management, HIV testing in the field, and over time building a clinic and expanding this clinic to not just serve those who are living with HIV, but our LGBTQ community, building a trans health clinic, and now becoming a federally qualified health center. So our mission and vision has updated, and we envision you know, healthy communities, a future in which equity and equality are the norm. And our mission is to be able to provide high quality, equitable, whole person and culturally responsive care delivered in an inclusive and welcoming manner. We really want to build and expand on our long tradition of care for AAPI, LGBTQ+, and persons living with HIV. And so, you know, this, if we go to the next slide, effort really for us was to make sure that we were maintaining our understanding of the communities that we started out with, our foundational populations, right? This study really for us was to understand what are health and wellness needs of our LGBTQ API community members in New York City. What are some of those social determinants that impact our health, and exploring maybe what are some delivery models that work for our communities. And why? Why is it that we want to look into this? I think we see that there is a progress, there is continued and great work that's happening in understanding LGBTQ needs in New York State, and also, you know, the disaggregation of data for Asians and Pacific Islanders in New York City that the Department of Health released, which also informed the study. So those are both really great studies and surveys. And I think we wanted to look at something that was at the intersection of LGBTQ and API. And of course, the reason is because we still face some of those issues that we used to face before. Traditional Asian American providers might be reluctant to serve LGBTQ people. And sorry, my toddler is home with me today. And our LGBTQ providers maybe only are able to speak English and are not culturally competent to serve our Asian and Pacific Islander community members. So sorry. So if we go on to the next slide. So what we're hoping is that this will contribute to the larger body of health and wellness studies for LGBTQ or API communities. Yes, honey, we're gonna feed you. Hold on, okay? Hopefully, with the intersectional analysis for these communities, you see what are overlooked needs. Okay, honey, we're gonna feed you. Okay, hold on. Yeah, and this was some of on the slide here are some of those studies that I had referenced earlier. Really great work, and highly recommend these documents or these studies. Okay, so moving on to the next slide. So some of you might have already seen, we might have already provided a tour. You might have been there at our ribbon cutting or have done some events at our lower level. Jackson Heights site of Apicha Community Health Center recently opened in June of 2022. And so now we are Um, we did our ribbon cutting last year in April, and so we are now providing the services for pediatrics, dental, adult primary care, and our lower level. I'm so excited to share now we are able to bring in staff to do some of the community engagement work that we're really excited about for the communities in Western Queens. So next slide. So the survey, we were able to survey 377 LGBTQ Asians in New York City, Asian and Pacific Islanders, and we did the study both confidential anonymous ways in 10 languages. Also to supplement the survey, we conducted in-depth discussions with stakeholders, focus groups of high-risk populations or high-risk groups, also individual interviews of those who are underserved, and we included assessments of our staff, frontline staff, physicians, and other healthcare providers. So I'm going to actually, sorry, just as a spoiler alert, these are the recommendations of the study, right? At the top of our every ranking question, our survey respondents said that mental health services and psychiatry was important and something that they were thinking about. We also realized that even though we are providing already free HIV/STI testing, we needed to publicize it more. Our survey respondents also indicated that sexual health and hygiene education was really important still. And as a new and emerging need is this this need for dermatology. Lastly, not a surprise, of course, is culturally competent, bilingual, LGBTQ sensitive, and non-judgmental healthcare. Okay, and so I will pass it on to Glenn to share who answered our survey.
Yep. And so I'm going to do the demographics on the slide. Thank you so much, Melanie. And thank you, Liliwan. Look, I got it. We have all been there at one point. And those of you who don't have a kid, just you wait. Anyway, I'm going to do the first set of slides on the demographics. Those of us like me who are data nerds always like, does he have representative sample? We have, but I'll make this available. Actually, Sabine, if you wouldn't mind putting into the chat the link to the slides that's available on Apicha's website, that'd be really great. Thank you for your support, Sabine. So our survey respondents were mostly Chinese, Filipino, Korean, and fairly representative of the community. In the next slide, we see that the sexual orientation leaned a little bit heavier on the gay side, but we also had a good number of people identify as lesbian, queer, bisexual. Next slide looks at gender and gender identity. We had a little bit of trouble with this question because we did not ask gender assigned at birth, which was a different question. When some of the methodological the methodological recommendations on how to ask the gender questions came out, it came out when we actually finished the survey. So had we had this, we would have had a little bit more of an accurate data. I will say there are people who are transgender who may have been female assigned at birth, but identified as male, as opposed to trans male. A number of people identified as queer, identified as female assigned at birth. So it doesn't always necessarily match up all the time, but we did get a good representation. On the next slide, we see that we leaned a little bit more heavier on the young people, 18 to 23 20 to 30 something. So I'll explain this in a minute. On the next slide, we saw that 60% of our survey respondents were bilingual. So we're really happy about this. We did the survey, as Melanie said, in upwards of 10 different Asian languages, both orally, in writing, and in different scripts. So that was really great. And on the next slide, we see that about a third of respondents identified that they had a disability, either self-diagnosed or clinically identified. So the next slide, Melanie had talked about the sorry, Melanie did not talk about this. On the income and education, we skewed a little bit higher. Most respondents to our survey identified as having incomes of over $50,000. Most had at least some college education. And I didn't want to perpetuate the model minority myth. And this is why we need data disaggregation, right? Is that because as a composite, when you put the communities together, we do have a higher rate. And let me say, the people who we surveyed were intentionally and specifically LGBTQ, lesbian, gay, bisexual, or transgender, self-identified Asian American, South Asian, Southeast Asian, Pacific Islanders. There's some reality that, the gays and the Asians as an aggregate are at actually a little bit of a higher income and a little bit of a higher education level. When you put them together, you kind of get, those dynamics. And so, you see the next slide, the way that we had addressed this is we did some special focus groups, some surveying of trans people, young people, youth, immigrants, people who are undocumented, sex workers, to make sure that our sample was more representative. Even though we had 377 in a good survey, we also wanted to look really closely. So the next slide really talks about what are the health and wellness needs that people ranked of their community. On the next slide, we see that the biggest health need was depression, anxiety, followed by STDs. And again, it was interesting that people said STDs and HIV because I was working for an organization that provides STD testing, but people said that they still needed this. On the next slide, when we asked them what is their most important wellness need, again, emotional health, but also health insurance enrollment came up more frequently. On the next slide, when we asked a composite question between health and wellness, again, depression, anxiety, addiction, finances came up. And then on the next slide, we see that the social determinants. So let's look at this issue of finances as being a barrier towards getting care. I said in a couple of slides that the majority of our survey respondents were actually making over $50,000, that they have jobs. And yet finances is a barrier towards care. And so when we did some surveying and some focus group on this question, what we found is that even people at the higher income levels have to self-pay for healthcare services. They have to pay, for mental health services, they have to pay for a therapist. Therapist isn't paid for by insurance, or maybe they are only approved for 10 sessions and they actually need a lot more. So that was a curious issue about people. Even 1 in 5 people who made over $100,000 identified that finances was a barrier towards getting mental health. On the next slide, STDs and HIV. Testing is a big issue within our community, treatment and support services. Now, doing these presentations, one of the questions came out is that who are the populations that are actually practicing unsafe sex and are not on PrEP? I came out in the 1980s, a long time ago, and back then I was convinced I was going to catch AIDS and die. I really did know people who caught AIDS and really did die. But now AIDS is a manageable disease. Now it's a preventable disease with the advent of PrEP, antivirals. But our community doesn't know it. So when we looked at the people who are having, and I do not have this slide, but we will be developing it, is who are the populations who practice unsafe sex and are not on PrEP? We found largely that they were gay men and transgender people, mostly Chinese, and mostly 20, 30 somethings. And so I made the recommendation to Apicha is that we really need to do stuff in Chinese. We need to do more outreach in this specific population. Next slide, shall we? Public health and public education is so much more important, especially now that we've realized this after COVID-19. So people wanted to find out more about mental health, addiction, emotional issues in cancer. I want to say a little bit about cancer. So if you looked at the slides very carefully, you saw that cancer actually came up. But in no focus group and no interview did cancer ever come up as an issue. And I was curious, why did at least 1 in 10, sometimes 1 in 7 people identify cancer? And when we asked survey respondents in follow-up interviews about this, it's because people didn't know about cancer. They thought it was terminal, that people die of cancer. How do you catch cancer? They don't know that you could live with cancer. And I thought that was really interesting because, I actually had lymphoma. I too am a cancer survivor. I am very much alive. My cancer was very treatable, but people didn't know this. They hear about cancer, they think that they die from it, and that's not necessarily true. So we felt that we need to do a little bit more education work around cancer, treatability, living with cancer, how cancer develops, and dealing with some of these other issues. Let's continue on the next slide, shall we? The emerging health needs, and Melanie talked about dermatology. And this actually, I think, gave Apicha a little bit of panic because they said, oh no, we have to provide a dermatologist now. And I said, look, it's not the thing that we really need to do now. But what we found is that every person has 5 healthcare providers in their life: a primary care physician, a dentist, a pharmacist, an eye doctor, and who's next? A dermatologist. Because if you have a rash on your arm, what is it? And what was curious in working with Apicha is that if you have a rash down there, what is it? Is that a dermatologist or is it an STD? Let's continue, shall we? So this is the emerging pharmaceutical needs. We're so happy that Apicha has a pharmacy, and Therese wanted to tell all of you that we also have home care delivery. So if you need pharmaceuticals, you can go to Apicha, a community-based, service-based pharmacy. And most of the needs are around depression, anxiety. On the next slide, we actually looked around what are the pharmaceutical needs, and we found that ADHD was actually fairly big among students. And I think on the next slide, it was deleted, but we found that women and trans people actually needed more antipsychotropic drugs, and immigrants needed more vaccines. Some of the studies that came out by the Department of Health talks about the health and wellness of our community, about Asian Americans, about LGBTQ people, but what about people at the intersection who have dual identity? And so we asked about people's health and wellness and how they felt about themselves and the behaviors. I was pretty happy. Most of us eat a balanced diet. We engage in self-care. We exercise regularly. Still, a few of us engage, drink alcohol, engage in party drugs or smoking and vaping. For the next slide, we also see that, while LGBT Asian Americans and Pacific Islanders identified that their physical health is fairly good, the emotional health was good, fair, or even poor. And, this is like after all the traumas and dramas that have been going on for the past 2 years. It's been a tough time in our community. On the last slide, we see that a data disaggregation. Here we go. In having a robust sample of nearly 400 responses only in New York, and for those of you outside of New York City, national capacity, we also have people in Westchester, Long Island, New Jersey. This is just New York places, but we were able to disaggregate by ethnic group: Chinese, Korean, South Asian, young and old, immigrants, sex workers, parents, gender, income, and also by borough. We only did Manhattan, Queens, and Brooklyn just because those are the boroughs in which we have the largest number of Asian American and LGBTQ people. And the next slide, we do this because we want people to see that, they need mental health services. No shame in doing some of this, right? It is a hard time. Free STD testing and publicizing more that these services exist for our community. Sexual health and hygiene education. There's still a lot of stigma in our community around sexual health and issues that are down there. It was remarkable that a couple of people had a primary care physician, but they didn't want to tell them about what was going on with their foreskin or labia or how to deal with a yeast infection. And these are important issues. These are our bodies. No shame, but still, Asian people, LGBTQ people have body shame, and social media does not help. Um, so we have to be healthy. We have to take care of ourselves and no judgment in whatever we do. So sexual health and really hygiene was something that came up. Dermatology, and then culturally competent, bilingual, and LGBTQ sensitive, non-judgmental healthcare providers. On the next slide, if any of you need a doctor, Apicha is here to support you. Make an appointment in Manhattan or Jackson Heights, Queens. We'd love your help and love to support you. Let me stop there and see if there are any questions that people might have. Melanie will join us too. Thank you. Questions?
Thank you so much, Glenn. I think we can maybe wait to see if other folks have questions and drop it in the chat. And in the meantime, we can do the data disag presentation from GMIT, if that sounds good. But please feel free to put any questions you have in the chat. You can also directly message me if you don't want to put it publicly in the chat. But we will have time after the Invisible No More presentation to also ask any questions. So I'm just going to go ahead and introduce Jimin, who is CACF's newly appointed data policy coordinator. We're so happy to have you and talk more about our data disag work.
Hi, everyone. My name is Jimin. I'm CACF's Data Policy Coordinator leading the Invisible No More campaign. I'm advocating for API data disaggregation at local and state levels here in New York. First, I want to thank Apicha Community Health Center, Glenn and Melanie, for sharing their amazing report and findings on the LGBTQ AAPI community. I just want to share my personal thoughts and say I appreciate that their report so much because this is a community-driven survey and assessment developed by an LGBTQ AAPI advocacy org. So one of Invisible No More's main priority is that data collection on our community should be developed by our community and must be for our community and for our community. So I found the report so inspiring and insightful. And now I just want to go over what the Invisible No More campaign is all about and summarize why data disaggregation is important to the API LGBTQ community. So CACF launched its Invisible No More campaign in 2012. We started the advocacy campaign due to the lack of consistent, accurate, and appropriate demographic data on the API community in New York. And at the time, we found that Asian Americans were often grouped with Native Hawaiians and Pacific Islanders, meaning aggregate data. So our needs in critical resources to uplift our community weren't met. So we decided to address this gap by embracing the importance of sound data as a matter of inclusion and equity. So ultimately, our campaign wants to develop policy solutions to fully address the needs of our community via disaggregated data to see the urgent need of all marginalized communities. So I know during the presentation here today, we were all discussing the terminology data disaggregation a lot, and I just want to take the chance to define some important terminologies and show an example of disaggregated data. So first, I want to talk about aggregate data. So aggregate data is information and raw data gathered and expressed in a summary. So in this instance, I got this from the Apicha's executive summary report, which all of you should check out. So the question was, do you engage in any of these activities nowadays? Eat a healthy, balanced diet. So when we do a summary, on average, 50% of API LGBTQ members say that they eat a healthy, balanced diet. But if we look at the disaggregated data, can you, next slide? For disaggregated data, we see a breaking down of data collected and compiled from multiple individuals. So we see Chinese, Korean, South Asians reported relatively higher compared to Filipinos and Southeast Asians who underreported that having eating a healthy, balanced diet. So this is just a very small example to think why data disaggregation is so important to understand the needs of certain communities within a larger API population. Next slide, please. So I just want to discuss why is data disaggregation important to the API LGBTQ community. So there are a few reasons. Number one, sexual and gender minority folks have unique lived experiences, health needs, and concerns that are hidden without disaggregated data. Number two, they experience disparities in mental health, disability, and healthcare access. And number three, quality data is needed to optimally plan programs, provide services, and other interventions to best meet the needs of API LGBTQ communities often ignored or overlooked. So in summary, what I would like to emphasize is disaggregating data is really, really important to the due to the significant health and well-being disparities that impact sexual or gender minority individuals who often come from a wide range of geographic and demographic backgrounds and really may have unique lived experiences, health needs, and issues of concerns that are obscured without disaggregated data. And I think this is a really good opportunity for us to discuss whether New York City has any data disaggregation laws that pertains to our API and LGBTQ communities. So the New York City data disaggregation law passed in New York City. CACF is really proud to say that Invisible No More campaign took charge with many other coalition members, which also includes LGBTQ advocacy orgs in passing this legislation. And just in context, this is New York City's first data disaggregation law. And I'm going to be just discussing the intent and the results of these laws. So the intent. So it requires all these city agencies such as ACS, Department of Health and Mental Hygiene, DOE, DOICD, Department of Homeless Services to incorporate a voluntary form of consisting of demographic questions on race, ethnicity, multiracial identity, and sexual orientation and gender identity. And specifically for the race ethnicity that pertains to the API community, agencies are required to provide disaggregated categories for the top 30 ancestry groups and languages spoken, and based on the US Census Bureau, which is updated every 10 years. And it requires finally public reporting of data collected, which is basically releasing all the data to New York City's open data where everyone will be able to have access to this data. But I'm going to just discuss the results from this law. So although this is our New York City's first data disaggregation law and it was really well intended, it doesn't give the urgent data that we really need. For example, the top 30 takes account across all ancestry, and only 8 API communities are represented within the top 30. And the law mandates all data being released online, but we also noticed that they're inconsistent data. And what we really want to advocate for is that our community's data should be quality data. And we really also want to prevent inconsistent data rolling out to the public, which could lead to wrong conclusions or stereotypes about our communities. And I think this is a really great chance to discuss what are CACF's priorities, specifically that pertains to Invisible No More for this year. So our first priority is expanding the Invisible No More campaign with our steering committee members, which includes Hispanic Federation, NYC, New York MENA Coalition. And we are really thinking about how can we make sure that data disaggregation is going to be as inclusive as possible so all communities are heard and represented. And the second portion of it is organizing collective pressure on New York State ops and agencies toward more inclusive actual data disaggregation. So just in context, Governor Hochul signed a AA and NHPI data disaggregation law in 2021, I think around December. And the implementation was supposed to start of last year, December. So we are building and we are just building relationships with government agencies to see how this implementation is properly rolled out and how we are accurately represented in the data. And we are also really grateful for the historic first steps of the first ever AA and HPI data disaggregation law in New York State. And the last portion of it is community education on the importance of a need for data disaggregation. So I guess this is a really great example as to of a community education where we are talking about data disaggregation law or data disaggregation in the larger context and the importance of it. So That is the end of my presentation. I'm more than happy to take questions if anyone have any thoughts or what would like me to expand on. Thank you.
Thank you so much, Jimin. Really appreciate that. And as Jimin said, if there's any questions, please feel free to put in the chat. We have quite a bit of time to answer any questions folks may have. We'll give another minute, but if not, we can definitely wrap up. Oh, looks like we have one question. One second.
Oh, Dr. Bay, you go first before me.
Hi, my name is Young Zabe. I'm the Executive Director of CIDA. We serve API community, including families who have children with disability and exceptional needs. My question is regarding the health outreach and also expanding the number of physicians who can serve API LGBTQI populations. Is there any the federal or even like a CACF level in an effort to expand the physicians actually the network who can serve the population with this particular needs. I think many the doctors and like clinicians are really empathetic about serving this population, but sometimes they do not have a knowledge or how to approach and even like network looking with the community-based organizations. So I'm wondering if is there any federal level or local level effort to reach out this in physicians group or even like universities, the medical university, to collaborate and then to inform them about the needs of our the LGBTI communities.
Well, I'll take the first stab at that. I can't answer it directly. But the reason why we're doing this is to actually do that. So often, no one cares about us. And unless we speak out and unless we talk about our community, we're often overlooked. And so when I did this engagement that we finished the report, I asked Apicha, so what's next? And they said, we want to roll this out to different community-based organizations, to elected officials, to say that our community is there and our community has particular needs. There's still a lot of homophobia and transphobia around Asian American providers. And I assure you, there are white and LGBT doctors who are not culturally competent. And so some of the work that we are doing is trying to do that education work. Whether there are services, I'll pass that over to Melody or CICF to do some of that work. I do know that Apicha is itself a community health center and they have physicians. So they are actually holding some of this work themselves. Melanie?
Yeah, thank you for the question. I think what I understood is, what is the current sort of progress right now in building that capacity within our, organizations or communities for API LGBTQ competent providers. And I want to say that it is a challenging sort of a work in progress. Apicha has been doing culturally competent workshop trainings with different social and medical service providers. In the meantime, as we're waiting for, I guess, more people to take up the mantle of, I think even in mental health, like, there is just so much need that we're seeing, but not enough providers that we can refer people to, both culturally competent or even, folks that can participate in either the types of insurances that our clients have, the Medicaid or like uninsurable, that I think there is the sense of like also wanting to build mental health care in what I would say like the informal community care. So the World Health Organization has this model of the pyramid of mental health needs, right? And that while you have these like resource heavy, psychiatrists at the top of this pyramid, maybe not so many people need that, and maybe a larger amount of people might need peer support, which can live in sort of community-based organizations. So I think we're also thinking about like, how do we also help build capacity around addressing some of those preventive or needs that maybe can be met that are not as high resourced as like, you know, mental health providers or psychiatrists, as an example, right? And I think something else that I was thinking is that I think that there, you know, Glenn had referenced this, that there's still some stigma that we, you know, we are trying to break down. And I think that exists even when we're working, you know, in the community. There's the story that our CEO and COO had of talking to, you know, an unnamed elected partner who had asked us when we were doing this presentation on the clients that we're serving in this person's district, had asked us, why do APIs need a separate health service? You know, like, why can't they just go to Callan Lord? And so we had to, our CEO had to then educate this elected official around, like, you know, the fact that, like, we have been invisible for all of this time. This is precisely the reason why, you know, organizations like Apicha was created. And so I think that there is this both sort of barrier that we're doing long-term work in. There is this, there are positions that are available, and we're working sort of with, with the candidates that we have, and also trying to find ways. Sorry, my child was sick, and so I couldn't bring her to daycare today. And so we're also working, how do we, in the meantime, meet the health needs that we can meet with the resources that we are able to, because, you know, people can't wait for, like, people to become mental health providers. You need to also build something now, you know, while we're waiting for those, like, really excellent LGBTQ API mental health providers that are coming down the pipeline. I don't know if that helps answer some of those questions. Yeah, so I think, like, also looking at healthcare in ways that can be, like, maybe it doesn't need a medical provider right now.
Yeah, I mean, I was, yeah, thank you for the answer. We'll be happy to talk to you later, and, you know, any way we can, and try to build a coalition around you, you know, work around you. So, but kudos to you. It's very hard work, and, you know, this is really not a special thing. This is a human rights, and everybody should be able to access the healthcare and the mental health support. And, you know, it's, you know, as a family member of LGBTQI the community, and then it's just, you know, it's amazing to see the number that you share with us. But thank you so much, and then hoping we can actually work for together for the further the perspectives. Thank you.
Thank you, Yan. And I also just don't want to underestimate sort of the existing organizations that are community-based organizations that are API and LGBTQ. They are doing a lot of, like, work in the community, and I don't think that Apicha would be able to do anything without those partners as well that are on the ground and maybe are not as resourced sometimes. So.
Well, thank you, but it's really informing. Thank you so much.
Thanks so much. Hi, everybody. This is Lloyd Fang from CACF, also co-lead of the Invisible No More campaign. And I just wanted to uplift Ebony's question. Are the inconsistencies that were seen after the disaggregation law in 2016 still heavily prevalent? Yes. In short, as Jimin, you know, put it, the intent was definitely there to get all of our communities, be it race, ethnicity, data disaggregation, or sexual orientation, gender identity, data disaggregation. The intent was there, but the impact we've seen, this is where we need to work on. And so the law itself mandates that 7 city agencies have to use this voluntary demographic survey to collect some of these this data on these questions. One issue that's come up is that agencies don't really see, you know, this effort as baked into their own internal processes across agencies, right? So there's this demographic form that they have to, you know, administer on top of every single other form that they're asking, you know, clients to fill out, right? So it's extra work, and it's not necessarily data that they can use. Agencies have shared with us that they have other processes where they're tracking race, ethnicity data, internally with clients that work more effectively for them. And so we feel like, we need to shift our efforts towards making sure that agencies actually have an updated standard across all agencies, right? That have the kind of disaggregated data by ethnicity, by language, that really meets our community's needs, as well as the needs of other communities, right? As Jimin mentioned earlier, top 30 ancestry groups sounds good on paper, but it's only like 8 Asian subgroups, no NHPI groups, given that it's population-based. So there's a lot for us to work on, and we are excited to embark on this effort with, different community stakeholders here, across communities like in the LGBTQ plus communities, as well as with legislators and different government folks. So please connect with us. We would love to work with you. And I see Felicia, you had a question?
I did for Glenn or Melanie. I'd love to hear some background on what it is like approaching agencies and collecting data on your side. I know that you all did most of the work to collect this really important data and to create this report, but was there any kind of collaboration between agencies? And what would you have appreciated in that working relationship going forward with this report?
So I'll talk about for the study, and then I'll pass it to Melanie to talk about the ongoing support. Apicha could not have done this work without so many of the people who are actually on this call. Some of you may have completed the survey yourselves. So we do want to recognize the other agencies. Look, everyone wants to do a needs assessment. And so it was really wonderful to have that support. We also get a lot of surveys. I don't know how many surveys you get. We felt, and I personally felt, really important that we go back to the agencies that supported us. We recognize them. We go back to our survey respondents who wanted a copy of the survey results and gave us an email privately to see the copy. Because, we do so many of these surveys and we never hear back, especially from graduate students, no disrespect. And so we wanted to come back. And so we're really grateful to those agencies. On page 349 of the report, you'll actually see an image of all the agencies that actually work with us. I'll try to pull that, and then maybe we can post it really quick. But let me pass it over to Melanie to talk about the continued partnership with agencies to do this work. Melanie?
Yes, thank you, Glenn. I think that a very big lesson to Apicha Community Health Center are, what are dynamics that we encounter as maybe an organization that has evolved over time. Sorry, once upon a time we were an advocacy organization, smaller as an organization, and over time we grew as an organization. And I think that we really wanted to make sure that we were hearing community partners and that we were genuinely investing in relationships with community partners. So I think the point that I'm getting to is that the study is not sort of a standalone in terms of our work with our partners. We try to make sure that even in other parts of our work, we're as much as possible being genuine in the way that we are connecting. So asking our partners, what is your goal? What is your agenda? How can we support and fit into that agenda? And if it doesn't work, that's okay. You can come back to us when it does work for you. So examples of that is we really wanted to be sure, like if we did an event together, we realized that actually if smaller organizations that didn't have a usual funding that's multi-year, we wanted to say, hey, how can we help sponsor this event that you have? How can we help support either materially or with people or with services? Sorry. And I think, okay, honey. And I think the other piece of this partnership that we hope to continue moving forward is Glenn really taught us a lot about how do we consistently connect? Because I think that was another issue that we realized we had, is that we had staff who are from the community who carry these relationships and consistently are I consistently work with Q-Wave, I consistently work with Lunar New Year for All. And so we would have these relationships based on our individual staff relationships. And then the challenge was, how do we make it so that it's organization to organization, and that we are institutionally remembering what we've done with organizations prior. Because sometimes we have long histories of work with, for instance, Urban Equality Project is a great example. I've had 3 or 4 different coordinators in Project Connect, which is our project for API LGBT members of our community. And so the Urban Equality Project has been a consistent and amazing partner throughout, the years since I took over that project in 2016. And I think for us, like making sure that we consistently track and how do we consistently support their genuinely in the investment of their work and their goals was part of our thinking. So when we went to them, so we would have ensuring that those asks were clear and not just for our own funding goals or our interest. Sorry, I don't know if that was overlong, but just thinking about those work.
No, I appreciate that. And Glenn, thank you for adding the partners below in the chat as well. Thank you.
If there are any more questions, we have 6 minutes left. Want to make sure. Okay, if not,
Something that
Go ahead.
sorry, I just wanted to do one last plug, Meda. Sorry, I meant to also do this as a plug for continuing partnership with organizations in this call and our staff in this call. I think we realized that when we did this community report back, Glenn had referenced that we did a community report back with some of our partners. And in that report back, we realized that, some of our partners actually have specific needs for their members and their organization. So an example is that the Queer Caucus of Drum was like, we still feel that lack of a safe space to talk about sex and sexual health. And so I think that they had asked us, is there a way that we can co-collaborate on a curriculum to talk about and create those safe spaces? And so we were like, yes, we definitely would want to partner and see how we can support you in doing that. So I think this would be just like a call, I see in the chat already that some people have said they're forming their own programs, and we'd love to see what are you offering, how can we support, and could Apicha's patients be part of your programming as well, if there are things that maybe we're not able to provide to them. So just like a call, let's talk afterwards, let's continue the conversation.
Thank you so much, Melanie. Yes, I also just dropped the emails of all of our presenters today. So please feel free to get in touch if anyone has questions. I think this was a really great discussion. We'd love to keep it going. And it seems like there aren't any more questions, so we can wrap 4 minutes early today. Again, that there should be a recording. We can share that out, and please feel free again to get in touch with any of us. But yeah, thank you so much for joining us today. Really wonderful conversation.
Thank you, CACF, and for all of you for what you do.
Thank you so much.
Appreciate it.
Have a good day.
Aw.